time, so I'm going to go ahead and get us started. My name is Rivet Amico. I'm with the University of Michigan School of Public Health, and I'm really honored to be here today to moderate this session, Bridging Mind and Body. I'm also honored to be able to provide just a few words of introduction and then let you know about the scheduling for our event. We've heard a lot about mental health throughout this conference all week. We've heard many mentions of mental health in plenaries, symposiums, workshops, posters, in the global village, inside conversations. We've seen mental health being identified as a critical social determinant of HIV, of treatment outcomes, of prevention. We've heard mental health and calls to integrate mental health squarely within HIV treatment and preventative care. We've also heard mental health feature prominently in visions of what effective, differentiated, person-centered care might actually look like. We've also heard and strongly believe that mental health is actually a fundamental human right. Mental health has been defined in many ways, but WHO defines it as a state of well-being that enables people to cope with stressors of life, to realize abilities to learn well, to work well, and to contribute to community. But challenges to mental health are at crisis levels in many parts of the world and in many communities. Estimates vary, but somewhere around 970 million people around the globe are estimated to be struggling with depression or anxiety. Specific to people living with HIV, 1 in 3 individuals experience mental health challenges, and with youth, it's 1 in 4, and that's probably a low estimate of 25%. We know these numbers are exacerbating and getting worse as we realize the outcomes of COVID-19, the impact of climate change, and the increasing exposures to violence and through war. This session focuses on the interconnectedness of mental health and HIV, and our speakers are going to provoke us to grapple with this powerful syndemic. There are shared social and structural determinants, including poverty, racism, stigma, discrimination, and again, increasing exposures to trauma, as well as a shared vision for sustainable, community-driven programs that can improve well-being among those living with HIV, as well as those at elevated risk for HIV. We're going to switch over to a community perspective, or actually continue to build on the community perspective with Sasha Volgina. I'm not going to get it. I'm going to keep trying. Sasha is with the Global Network of People Living with HIV. She's a community networks and partnership manager and has worked towards really the improvement of mental health from a perspective of global health and human rights. She'll be speaking with us about the community perspective, mental health monitoring, interventions, and a little on personal experience. Thank you so much, Sasha.
So I think, for our movement, and for our community, it was, the actualization of the mental health happened during the COVID-19 pandemic, because it was very hard and very painful for the communities in general. So it was, so the mental health state of people in HIV during COVID pandemic was very challenging. It was fear to lose access to medical care, to treatment, which was sometimes, very true, and fear to get infected with COVID, and that also, was very, very hard. Growth of stigma and discrimination, especially towards people from key populations, were also involved. Yay! So growth of stigma and discrimination, especially towards people from the key populations, and of course rise of violence, domestic violence, which was faced by women living with HIV a lot, and just in general also. And of course, loss of income and financial situation. Our communities are not rich. So, but COVID, yeah, made it even more complicated for us. So what we've been doing? Support hotlines, yes, so just our people answering the questions, helping, navigating, all of that. Delivery. So we've been on the front lines, just delivering our treatment, commodities, everything to people, just carrying that on bicycles, water rollers, don't matter. Shelters and social support services were very, we opened quite a lot of them. Of course, self-support online groups, and that's how the journey of going online starts. That was the starting point. We'll speak about that more. Psychotherapy, of course, burnout prevention among community-led organization workers, because people were working 24/7. It was quite intensive, so we started first, to implement burnout programs. And many services were adapted to function online, which finds out to be absolutely crucial when the war started, when there was a full-scale invasion of Russia and Ukraine. So in the beginning of invasion, of course, people were working, really very extensively. It was very, very hard and very, very packed, let's say it like that. We managed to convince donors who were previously giving us money for the mental health and COVID situation to give, to reprogram that money for these programs for burnout. It wasn't only for activists, it wasn't only for our social workers, it also was for the doctors and for everyone. You have to understand the conditions people were working in. It's like on the shelving, in very, hard, some of them evacuating themselves, evacuating their patients, so it was really very intense. In 2023, we believe in HIV organization, Positive Women Ukraine. From the beginning of the war, we started to combine health services together with the humanitarian help. Actually, it works very well for the adherence, I can say, because people are, when in the crisis situation, people are thinking about taking their IRVs in the first role. No, they think about where to sleep, what to eat, things like that. So we started to combine the services together, and it works very well, but at some point we realized that the issues of mental health are also very important. So now, and this program is still running, so these are the results of the 2023, so over 300 women, they received the online psychiatric counseling, which is also very important. In some areas it's very hard nowadays to receive any medical help. So having opportunity to get it online is priceless. So the project, as I said, is still working. So special mental health hub was opened by community-led organization in Poltava for internally displaced people. That's also very complicated population group, which experienced quite a lot of problems. And I can say, indeed, the COVID-19 experience of online services was life-saving in our war conditions. So what about refugees outside Ukraine? It was a shock for many of our community organizations outside Ukraine. What we've been doing previously, we usually were dealing with the people trying to accept their diagnosis, but not with the refugees. We were really shocked, what to do with people who are just coming into the countries, laying on the bed, looking into the wall, and are not able to do anything. So we immediately found money, and we immediately started to implement very great programs. So what are the main things we saw? So the self-stigma, of course, right? People, they are somewhere in the Europe, somewhere outside their normal, conditions. Then fear of being discriminated, of course, and honestly, also we have to understand that besides it's written on the websites of the humanitarian organization, no one is discriminated. In the reality, people from key populations or living in HIV are denied shelters, are denied evacuation process. So this fear is actually based on experience, so it's not like, you know, coming just from us. And of course, these mental health problems were associated, you know, with the deviant and risky behavior, and alcohol and substance use. That's what's coming next. So in Moldova, I think we've done a really great job. So the local organization, a community-led organization, Pozitiva Initiativa, they were providing the primary and specialized psychological support and mental health services. They have done a Telegram chat board because the amount of people was, you know, you can't work with all of them, like it's not doable, right? So it was Telegram board, which was, you know, you're answering questions, and then if you are in a condition, you are referred to the specialist, and then the specialist is working with you, right? It also had some tips, you know, for self-care as well, yeah, so that people can take care of themselves. And yeah, quite a number of refugees received the screening services and special counseling. My personal experience, so of course the first year of the war was very extensive for me myself. I was working 12 to 14 hours a day. My husband joined the Ukrainian army. I was having refugees hosted at home, so at the end of the day I got into depression. Also those of us who knows what it means waiting for someone who you love, you know, who is on the front lines. It's a very special condition, honestly. So yeah, I went to the full depression treatment. My husband got MDR tuberculosis. He is now back on the front lines. He is alive. We are slowly but slowly getting better. He is getting the treatment for his PTSD, so I hope we will be okay. But just for understanding, you know, it's not only about our client, it's about ourselves, right? So, and we also do understand that, you know, just for human rights, not only for people living in HIV, but in general for human rights activists, because nowadays it's getting more and more, you know, more and more countries have this kind of regimes like Russia, the country I'm coming from, you know, the pressure towards human rights activists, towards journalists, towards human rights defenders is growing. We also have to understand that we have to support these people. So in the beginning it was, you know, several years ago, many years ago actually, it was human rights defenders, lawyers in Russia. They introduced psychological support because it is very hard to defend in the court the person under repression who is not able to defend him or herself. So they started to work with psychologists in order to support their clients so that they can win these cases. Yeah, it was growing and growing and growing, and nowadays, unfortunately, also the lawyers themselves, the journalists themselves, they have to escape Russia, and they have now to establish special prevention programs for suicidal behavior and things like that. So unfortunately, it's getting worse and worse, and I think the main thing here is to manage to save those who are still resisting, those who are still working towards the improvement and just saving our community, and providing this kind of help. And my last slide is about what we also see in Ukraine is growing substance use. The war is not over, we all know, and it's not going to be over very soon. So what we see is that quite a lot of people, you know, are in a very bad condition, and we are making now the research with the Johns Hopkins University. So it's about PTSD, anxiety disorder and depression in the key populations, people living in HIV, with a special focus on men in armed services and veterans as well, women and people who use drugs. So we are going to look at these interactions between, you know, drug use, war, being HIV positive. So yeah, we're still waiting for the results. We're still in the implementation. Of course, all that is not research for research. We're trying to understand what are possible interventions in the conditions we have. It's very timely, I think, because Ukrainian government is also trying now to introduce a reform in mental health and to make it to the primary care, because previously it was very specialized. Now they're trying to put in the primary care level. So fingers crossed, we will be able, to make that done. And the last thing I wanted to say, which is also very important for me, our heroes, those who were, protecting Ukraine, who are protecting Ukraine, they're coming back, sometimes without arms and legs, and they start using drugs. And I really think we should decriminalize drug use in Ukraine, because then putting our defenders into prison for just not being able, to deal with their mental health problems, it's so unfair. So I also hope that, this decriminalization will happen and that mental support will be available in Ukraine. Thank you.
So I'd like to introduce someone you probably already know, but Dr. Lorraine Sherr, who is a professor at the University College London. She'll be sharing with us an overview of contributing factors. She's an editor of 3 international journals, including AIDS Care, and has multiple projects and collaborations that focus on mental health in children, adolescents, and their families.
Thank you, everybody. Welcome to, as always, Professor Sabin in the audience will know we always have a discussion about mental health. It's always the last session on the last day, but it's the best. So I've been asked in about 10 minutes to try and overview the entire mental health of the pandemic, and I'm going to give it a good try. So we've always known from the beginning of the pandemic that there's kind of scales of balance between biomedical and psychosocial. And in a way, the early years showed a schism, but I'm really quite pleased to see the integration agenda coming forward and mental health suddenly being spoken about in an important way. What do we mean by mental health? Well, it covers a lot of things that are measured in studies, things like depression, things like suicidality, anxiety, post-traumatic stress, but also some positives, post-traumatic growth, stigma, resilience, quality of life, coping, adjustment. And what about hope? Hope and happiness. So today what I'm going to try and look at is the mental health missing component in the AIDS response for both adults and children. Very often when people talk about an issue, a thing, it's assumed about adults, and then locked up in a side room is the discussion about children. So when we look at the life course approach, we need to look at them. I'm just going to pose 3 questions. What is the rate? What are the ramifications? And what have the responses been? And if we can go home knowing those 3, I think we'll have made some good progress. So for the rate, I will have some slides, but all you have to remember is the word high, not in the sort of cannabis sense. But the rates are high. There's lots of systematic reviews, depression, we've done a whole series of reviews, and the rates vary, the rates are high, anxiety rates are high, and looking at studies on suicidality and suicidal behavior, we see them. And in a way, this slide tries to compose for you what has been done and what we know. And I think there's incontrovertible evidence that whatever the group, wherever the study, if you bother to measure it, and sometimes what's actually happened is you look at clinics where they always will take viral load, or they always would look at weight, a number of variables, and you say, why don't you just simply introduce simple, straight measures of mental health right at the beginning into your routine care? Maybe that's changing. Turning to children, there is a paucity of data on children. Looking at some of the studies, 25% any disorder, if you try and count, do they tick the box on any mental health issue, and 30 to 50% emotional behavioural difficulties. That's been a nice review done a few years ago. It's across the care continuum. Often it's fueled by things like stigma. Stigma is not good for mental health. And of course, stigma plus poor mental health is not good for risk. And then we have cascading down of depression and suicidal thoughts, which are very distressing and depressing. Then we should look at specific groups, which I'm going to talk a little bit about work we've done with HIV and pregnancy and adolescence. So you have these clustering. We should just abandon the silos and look at multiple issues and multiple drivers. And of course, some really good studies that have looked at beyond the HIV people who are living with them, but what about the children who have been exposed in utero? Very often they say, you don't have HIV, get on with it, but actually those children might have challenges and issues living in the family. So I'll just give you this interesting graph just to put some perspective on it and the complex interactions. This is a study that showed, and you can just look at the stepwise slant. The first group is this group, which are a comparison group of adolescents. This is adolescents living with HIV, and it's any common mental health disorder, it goes up. What about pregnancy? Pregnancy itself in adolescents has an impact on mental health. But what if you put all three together and you have women living with HIV who are of an adolescent age and pregnant, and you can see it going up high. So I think you'll agree with me that there's a lot of places to study and the rates are high. So what are the ramifications? They're enormous, and I can't in these few minutes describe them all, but I think I'd like you to look at them as direct. Direct is mood, quality of life, treatment engagement, care engagement, relationship, and of course things like disclosure. And then we get to the indirect effects, and those I list a few, but there are many. Things like attainment and achievement are indirectly affected, disengagement from life, from relationships, economic issues, and these ramify. So if you have poor mental health, then you lose your job, then you lose your income, and you kind of get this cascade on employment and social. And the nasty face of violence creeps in, and very often mental health is either accompanied, triggered, or affected by violence. And I'll just give you one interesting study where they've tried to look at unpacking and understanding what are the drivers of mental health distress and giving a clue to where we could put interventions in and what are the ramifications. Well, clearly this study shows a real excellent example of it comes up to our non-adherence, which is not what anybody wants. So what are the responses? And I think here we have some good news stories, but some cautious ones. We need to build an evidence for effective responses. Integration of mental health is doable, and there's some good literature on that, good systematic reviews. It's doable, let's go on and do it. Adolescents in low and middle income countries show that interventions really are in nascent stages, but they're there. We know there's a recognition of services and provision. We also know that there's a whole movement for task sharing, and I want to spend a minute to talk about that. One thing I've heard in this conference a lot is the word lay. And again, not unlike the getting laid lay, but use of lay people. And although we love lay people, I do worry that mental health might be having a shot in the arm with lay providers, but at the same time a shot in the foot. An excellent review by Van Hoover has shown that if somebody is trained and the intervention is conceptually strong, it has a better efficacy. So if you delegate all of mental health to lay providers, where they have had nothing in the past, you will see a dramatic benefit. But is that good enough? Is that good enough? I think the lay providers should be trained, enabled, paid, and given a proper career trajectory so that they can then sit at the table and speak at the decision-making level, not just at the provision level. Mental health interventions, so really our data is showing that they're there, they can be effective, and they need to be rolled out. We know, for example, that the front line where community-based organisations are, where the community is based, really deliver. And up until a few years ago, there was absolutely no outcome evidence on psychosocial impacts from CBOs. The King Report in 2009 was the most quoted study where nothing had happened. They couldn't identify a single study where there was an evaluation. And then a noise was started. And Sarah Skeen, by 2017, was able to identify 17 studies that met criteria, the King criteria, and showing 15 studies with effective interventions. So the snowball is out of the cage, and it's rolling down the hill. So I think we do have effective interventions, and we can see an absolute change. And this is just some data from CBO attendance, a plug for community-based organisations who are the grassroots and who are doing well. And this is just to show in our data in 28 organisations across Malawi and South Africa, the effect directly on mental health. And you can see abuse went down, domestic violence, suicidal ideation, depression, stigma, a profound impact. Don't miss over digital. There's a potential to scale with digital, and I won't spend a long time on it, but they really increase adolescent adherence. They show quite a lot of merit in terms of usability. They reach places that other interventions can't reach, and accessible specifically to younger people. Text messaging interventions have been really, really useful, and it's quite simple to do. So there's a really nice systematic review of 7 studies showing them to be effective. So we've got tools in our hand, we now need to use them. Cash transfers, there's good evidence of benefit, and I think we've got to the point now where we need to look at complex interventions being a no-brainer. Don't simply do one intervention, and there's groundbreaking work by Lucy Kluwer and Alexandra Tosca and the group in the Accelerate team, who've tried to meticulously and methodically look at the impact on mental health outcomes of providing combined interventions, combining more than one. And what they find is the more you combine, the better the output. And having 2 or 3 is excellent. And then we've done a study to show how many is optimum. And it's very good for policymakers, where actually if you just simply make 3 combinations, you can extremely affect the outcomes and benefit those. This data is just trying to put in, so that you can see what these combinations do. We called it stacking the odds, but having no intervention, we had 3% retention in care, having cash grants, somebody accompanying, somebody just being kind, emotional support, having time for them, and being stopped with drugs. All had a kind of 3 or 9% effects on retention, but what if you had them all? It zooms up to 70%. So these combinations really are the way to go, and it's doable. So I'd end at this point saying we have areas of concern, roll-out silos and skills, attention and integration is very important. We're at a time when funding and resources are facing a crisis, and because mental health is the last to be recognised, we have to be very sure it's not the first to be cut. There's a need for complex models. We need to understand there's a broad definition of mental health and not go to a narrow, tokenistic. You see studies say, oh, we measure depression. I say, hold on, there's much more to mental health than one single marker of depression. And I think what you see from my very rapid review and overview of a lot of thoughts, that there actually is evidence. The evidence is there. It wasn't there 11, 10 years ago. My question to you, but not to you because you're in the room, clearly you are the people, it's to everyone else outside the room, is where is the action? Thank you.
So we have just a couple of minutes reserved if anybody has questions, and I can't actually see the microphones.